right, welcome everybody to your monthly one eligibility learning series. Today we have two topics for you. We have an announcement about a contact update project, and we also have a larger topic about other health coverage, how it works in our system, and guidance for community partners to report that other health coverage and changes in it so your clients and your members can be sure to access their coverage properly. So with that, we have a few introductions. My name is Deanna Simon. I'm on the Community Partner Outreach Program with Oregon Health Authority. I'm one of the regional outreach coordinators, and I also help to make sure that we're getting information out to our community partners that you need to best help your clients and your members. And we have a whole team of people that are over at our agencies that support you as our community partners. We have a few of them here today, and I'm going to save O'Donnell for last. If Jessica can say hello, that would be great.
Hello everyone, this is Jessica Diaz. I work on Deanna's same team at CPOP, and I am the provider outreach engagement strategist as well as your tech support for the day.
Thank you, Jessica. And Christy. Christy, do you mind introducing yourself?
Good morning. Can you okay? I'm really having difficulties with my sound.
I can hear you.
Perfect. I'm Christy Taylor. I'm a medical eligibility policy analyst, and I work a lot on the One System.
Christy has her hands in many, many things, and she's one of our great subject matter experts that we rely on. She's been working with CPOP and community partners for many years. She truly gets your work, and she really knows the TPL side of things. So she's here to be our subject matter expert today. So thanks, Christy. And O'Donnell, can you introduce yourself? And then actually, I'm going to introduce you first for a moment. O'Donnell's also on our policy team, and O'Donnell's going to talk about our first announcement and topic today. And this is very present, making sure we have people's updated contact information. That's a big effort that we're pushing out right now. So O'Donnell's going to talk about one of the elements of that. O'Donnell, if you can introduce yourself and then let me know when you'd like to change the slide.
Hey everyone, my name is O'Donnell Arrington, and I am on Christy Taylor's team as a medical eligibility policy analyst here for OHA, and I help support the CPOP team whenever we need me to, so here I am.
Excellent. Well, thanks for being here.
All right, so I'm going to do a quick background on this notice. We've been kind of spreading the word for this notice over the last couple of weeks, and so you may have heard about this, but I'm going to give a quick background, right? So we're doing multiple strategies to try and connect with individuals as the PHE is ending, right? So one of those strategies is to do what we're calling a courtesy notice. And the goal of this notice is, one, let people know that, hey, there has been a public health emergency going on, and it will end at some point. We also want to stress for people that the most important thing they can do to make sure they keep their coverage is to keep their information up to date with us. You know, the letter's not asking everyone to go, as you can see on the screen, it's not saying, hey, go verify that your information is up to date. It's just really reminding people, hey, if you do have a change, make sure you update it with the agency. That's the best thing you can do to make sure you keep your coverage throughout the unwinding process. And the letter also serves kind of a secondary, has a secondary purpose, we'll say, and that is we are going to be tracking returned mail on the back end to help the agency get a better understanding of cases that we have out-of-date addresses for, right? And so the one thing that we're really asking of community partners based on this letter is to just help people as you normally would. If people come to you and ask you about this letter, just help them understand that their benefits aren't changing. We just really want to inform people that the PHE will be ending sometime, and it's just really important to keep the information up to date. And this letter will be going out to every medical household in the One System. So we're sending out about almost 900,000 letters, and they're going to be going out at a rate of 25,000 per day, which started on September 26th. So people may not have gotten a lot of letters yet. So the strategy was to do a slow trickle of the mailing, so we wouldn't just get bombarded with sending out, a million letters all at once. So when people bring these in or call you, just provide that same great service that you always do, and let them know that just the most important thing they can do is keep their information up to date right now. And if they get a letter from us, please respond to it. We've heard a lot of stories over the pandemic of people not necessarily checking, reading the mail that the agency sends, and we really want to let people know how important it is that if we send you a letter, really need to open it, read it, and respond if we're asking for something. Next slide. And then this is just a close-up of the messaging of the letter. So as you can see, we're really just hammering the point home of keeping information up to date, checking your mail, and providing resources for individuals to update their contact information if they need to. And this PowerPoint is a resource for you all, so we decided to share the links for all of the notices. And it's also worth pointing out there's two versions of the notices. So one version is going to go out to cases where the only medical benefit is a Medicare Savings Program or MSP program. That's a much smaller population, only about 50,000 letters going to that population. And then the rest of the population are going to get the letter that you see here on the screen. The MSP letter has a slightly different messaging to it, just because of individuals in that program aren't necessarily familiar with the Oregon Health Plan branding. So that is how we chose to split up the populations. And
thank you. Yep. Oh,
yeah.
So those are really our slides. We'd like to take a moment to see if there are any questions about this letter. We're curious to know if you've seen this letter, if any clients have brought it to you. So if you have any reports on that, you can type it into the questions box and we'll be able to see it. And we would love to know if there are any questions that we can answer for you.
And I'll proactively answer one question. You might notice that the languages that the letters are translated to differ slightly, whereas the OHP letter is translated into a lot more languages. That's because of the size of the mailing and just the different languages that were included in that. The MSP was such a smaller mailing, didn't have as much variation with languages.
We have one person saying it's their first time hearing of this. But somebody did see the CPOP update with the generic template of it. But now you have a link to the actual letters.
Yep.
And you can always look them up in the form server, right? So we gave you the form number so you can look it up there. And we have a question, the eternal question, Donald, is will OHP coverage end if the mail is returned?
So this letter that's why we're trying to brand it as a courtesy notice, right? No action needs to be taken from this letter. So this is really just helping individuals understand how important it is to keep their information up to date. The reason why we are doing returned mail tracking on this letter is to help the agency get a better understanding of how many cases we have with out-of-date address information, because throughout the pandemic, that is just something that, because of resourcing, we just haven't been able to keep up on. And so it'll give us a really good baseline information about that. And then what we're going to do is try and use that return mail information to do some targeted outreach on the back end. And we're going to start that process with community, with CCOs. And then we're going to see how much outreach CCOs can do. And then we're going to try and look at if the outreach workers can help on the back end. So we're still trying to figure out kind of what that outreach, that targeted outreach might look like for CPs. But as of right now, we're really just wanting you to, again, keep providing that great service that you already provide and help people understand the importance of keeping information up to date.
Thank you, Donald. I'm going to add one more piece of context here, which is about when the public health emergency ends. And of course, we don't have a date yet, but we know it will end at some point. And at that point, we will need to make sure people are still eligible. And some people will be automatically renewed and extended, but some people will need to respond in order to keep their case updated and make sure we have the right information. Our concern is that when we send somebody a letter and we say, we need additional information from you. We think you're still eligible, but we need this additional information. If they don't respond, then at that point, their benefits risk closing. So we are trying to avoid that non-response by minimize it by making sure we have proper contact information for people. So this is part of that larger effort, and you've probably been hearing a lot about updated contact information, and you'll continue to hear about it. And this is one of those pieces.
Yep.
Yep. So question here, how many of these 4148 letters are going out?
They are going out to every active medical case in the one system. So approximately 900,000 letters.
Okay.
I think it's like actually 860,000 or something.
One per case, not one per person. Right.
One per case.
Yep. And another question, by Medicare Savings Program, do you mean QMB Basic, SMB, and SM? Can you just define the scope of Medicare Savings Program?
those non-Magi, non-medical programs that help individuals with their Medicare payments. Yes.
Right. So to answer another question, that only people who are on Medicare will have those Medicare savings programs. And some people only have that assistance paying for their Medicare costs, and they don't have the health coverage. And that's
exactly
what that extra letter that is only going to 50,000 people will be. We did not show a picture of that, but you can look it up on the form server. It's 4148A, and we did put a link to the English version.
Yep.
All right. That's all the questions that I see for right now, O'Donnell, but if anybody has more questions, please feel free to put them into the questions box. We will be able to answer them and send that answer to everybody, and it will be anonymous. Nobody will be able to see who asked that question, so feel free to ask away. We can respond to you directly or reply to all if it's relevant to everyone.
And thank you for giving me, giving me the time to present here, and appreciate all the work that UCPs do for us, and looking forward to seeing feedback from this letter. I'm sure Deanna will share it with me if we get some.
Oh, yes. All right. Okay, so we are going to move on to our next topic now. Our next topic is about reporting third-party liability, which is also known as other health coverage. We have some things that are going on in our system, a couple updates that we want to let you know about in the one system that you'll be seeing, and some guidance for you. This is definitely a team effort, I would like to say. So even though I am presenting these slides, that doesn't mean I'm the one who knows everything. We have our policy team here and Jessica as our provider strategist to back me up, and it really takes a village. So thank you for being part of my village. But I will start by level setting for all of us to make sure that we all know that third-party liability is other private medical insurance. And many people can have that in addition to their OHP. The reason it's important is that providers need to bill that other coverage first, and OHP is only a secondary payer when somebody does have that other medical coverage. As a side note, those with other medical coverage will generally remain on OpenCard. And the challenge here is that we report this third-party liability or other coverage generally through the one system. There are other ways as well, but it needs to ultimately get into MMIS, the Medicaid Management Information System, because that is where providers look to see what coverage somebody has and therefore where to bill. So if that other coverage is not going through all of our systems, including MMIS, and showing properly there, it can cause billing issues or access to care challenges. I know that there are some, actually we'll talk about that in a minute. There's a little note here, which is that some folks can have a choice between OpenCard or a CCO, and we're not going to go into that. But for example, folks with tribal coverage can choose to be on OpenCard or on a CCO. So there's some nuances, but for the most part, these are the high-level talking points we wanted to make sure everybody is on the same page about. Christy or Jessica, did you want to add anything here?
This is great. Thanks.
Yep.
Okay. So anyone who's applying in the one system, or really for health coverage through any format, is required to report all other health coverage. And we want to be clear that that includes common things like employer-sponsor health coverage, like coverage through a job, or commercial health insurance, for example, Medicare supplements or any other private commercial health coverage. But it also covers things like student insurance through universities, coverage provided by somebody who doesn't live in the same household as the client, and any additional non-OHP coverage, even if it just covers dental or just covers vision. So any other coverage, it doesn't have to be major medical coverage, falls into that category of TPL or third-party liability and does need to be reported on an OHP application to make sure people are getting proper eligibility determinations and proper CCO enrollments, and that their providers can bill properly. Now, there are two known issues with TPL. TPL has been the hot topic recently because many of you as community partners are experiencing that the TPL is not showing properly in MMIS, and therefore people are having billing issues and access to care issues and enrollment issues. So we have taken all of your cases that you've sent to us. You've been amazing in sharing those details. We've looked into it, and here is what we found. We found that, first of all, TPL changes for one individual were being applied to all people on the case. So some of you found that you had a client who all of a sudden got disenrolled from their CCO and you couldn't figure out why. That could have been one of the reasons. And the other thing that we realized is that TPL changes reported in the one applicant portal have not been showing consistently or as often as we thought they would in MMIS. So Christy, can you speak, just so those assisters who might be new have a sense of some of what's going on, what some of the one or two of the challenges are that might present here?
It's pretty technical. I'm just going to say that sometimes our data from one errors out when it tries to transmit to MMIS for different reasons. We realized recently that we get reports from all of you pretty often that says, hey, the information I'm putting in one didn't make it to MMIS. It's not showing up. And as we started investigating, we're realizing that perhaps more were erring out for different reasons than we anticipated or originally ever understood. And so we've been doing some research into that to see if we can help, I guess, mitigate some of that. That can always happen when it's an electronic interface between two electronic systems to a degree, but we want to try to minimize it, obviously, and we've been working on that.
And I'll speak to that again in a minute. So let's start with the first issue. When it used to be that when someone entered a TPL end date, so if their other coverage was ending and they reported that for one individual on the case, all individuals on that policy would have their TPL ending in the system. So that is the first one that is being fixed. As far as I know, the resolution will be going into the one system sometime in October, and new data fields will be added so that community partners or members can end TPL at the individual member level instead of at the policy level, which would impact the entire household. Is there anything else you want to say about that, Christy?
Not at the moment, unless there's questions.
David or Jessica, are there any questions that we can address at this time about this issue or TPL?
Not about this particular issue, but we might circle back to something once we're further.
Thank you. Perfect. Okay. The second issue is that TPL was not changes in TPL or even the reporting of initial major coverage or any coverage has not been showing in MMIS. And again, MMIS is that system of record that providers look to see what if somebody has Medicaid and if they have other major medical coverage. So this is what Christy was alluding to. We have come to realize that not all TPL entered into the one system is making it to MMIS. And one of those reasons that I think is useful for all of you to understand so you know what our guidance is about is that and actually I'll show you a picture of this in a minute. So the one insurance carrier name in the one system is a free text field. You can type in anything you want. So if somebody has Providence Choice, maybe they're typing in Prov, or maybe they're typing in Providence with a typo, or maybe they're not typing in the choice part, just Providence. The challenge there is that MMIS has several thousand predefined carrier name values. Hate to read off the slide. What that basically means is that they're predetermined. So whatever somebody puts into the one system must match with one of those predetermined names in order for that record to match and show up in MMIS. When people put in typos or abbreviations or an incomplete name, that is unlikely to happen. And all those that do not match get kicked out to an error report. So this is what Kirsty was alluding to, where she said this is happening more than we realized. And that error report has so many errors on it that it's not a body of work that we can consistently work and keep up with. So the agency is looking on for possible solutions. But in the meantime, we wanted to get this information out to all of you as our community partners in the spirit of transparency of a piece of this that is not working well, and give you some guidance about how to make sure your clients are getting what they need. So we're going to go into some guidance and show you what that looks like. And in fact, before we go on, I think that one example of where this shows up, and I'm sure many of you have experienced a variety of challenges with TPL reporting. But Christy, you were sharing with me a Kaiser example, and I'm wondering if you can speak to that as to how changes in TPL showing up in MMIS can cause access to care issues.
Right. Yes, I think this can be experienced, unfortunately, a lot at the pharmacy, for instance. So what we hear a lot is if someone had TPL, it is now ended, but it's still showing up in MMIS, and they go to the pharmacy to try to get a prescription. The pharmacy looks to verify coverage. It sees that TPL, and that's who they try to bill. And that TPL denies it, and the pharmacies are often, unfortunately, reluctant to try to keep billing other secondary insurances. And so then the member ends up with an access to care issue. It can also happen if the provider network for the TPL policy is different from the provider that the person's trying to access now. It can also cause barriers in someone being able to access care because their current provider might look at that TPL. For instance, Kaiser has a specific network of providers and say, we don't take Kaiser, but we can't see you. And so it can present in a lot of different ways. It can prevent someone from getting immediate services when they need it.
Thank you. All right, so we're going to launch into some guidance. The context here that I want to share with everyone, that we want to share, is that there's a reporting hierarchy, and this is different than what we have advised in the past. So please note, this is updated guidance. We always want you to report other health coverage in the one applicant portal, if at all possible. One needs it for accurate eligibility, and then we need it for proper CCO enrollment. So if you're going to report it through the one applicant portal, that is the only place you should report it. You shouldn't double report it right from the beginning, as we have advised in the past. Okay. And in fact, in the applicant portal, we wanted to show you what those fields look like, and we want to encourage you to complete as many fields as possible. So you're all familiar, I presume, with the fact that some fields have asterisks and some do not. Asterisk fields are required, but in this TPL other health coverage screen, even though not everything is required, we want you to fill out everything possible, because that is how we get a complete record, and it's more likely to show up in MMIS. So that's the first thing, is fill out everything on this screen if at all possible to minimize the chances of follow-up. But I also want to acknowledge that even if everything is filled out, that doesn't guarantee it will show up in MMIS. So We'll get to that in a moment. We also want to point out that there is an update, and Christy, I believe this already went into effect. Is that right?
That's correct.
Okay. So on the other health coverage screen, it asks, what type of health coverage is this? There were some old options that really didn't cover what we were looking for. The old options were, is this private medical insurance? That is very, very broad. We have changed that entry, and the new descriptor there doesn't just say private medical insurance. It says private policy, not through an employer, includes at least doctor visits and prescriptions. So that's what we're talking about with that first one. And then we have a second option, which is insurance through an employer. And we have a further clarification now. It now says insurance through an employer includes at least doctor visits and prescriptions. Because if it isn't that major medical, we want to know that it's dental only, for example. So we have a third option for dental only, even if through an employer. So hopefully these three options and their changes make it more clear about what type of coverage you should be selecting for which option. The next thing we want to show you and alert you about is that we have this health coverage information, and we ask, what is the name of the insurance company? This is that free text field that we were talking about earlier that needs to match up with one of the several thousand predefined names of carriers in MMIS. So the question is how to make sure this has a higher chance of matching, right? So what I'm saying here, what I said here on the slide, or what we said, is enter the name of insurance company exactly as it shows on the insurance card. That will help. And of course, avoid abbreviations and double check for typos. So that's something that you can do to help ease this process. All right, before we move on to what happens if reporting in one isn't working, do we have any questions to address, Jessica?
So we have quite a few questions. A lot of them are focused on MMIS particulars, and I'm not sure we have the right folks here today to really dig into what shows up on MMIS and how.
Thank you.
And then I'd love to lean on the policy folks. Christy, we have quite a few questions and people are very engaged, but I want to make sure we're focusing on the ones that relate to the topic at hand, and then we can circle back on some of the other ones.
I also think that capturing some of these questions, even if we can't answer them today, it seems like there's some that we might have to investigate a little bit and think about and provide a follow-up set of answers. So these answers are really great for us to know what you're grappling with, even if we can't answer them today.
There is a question, what do you do if there's more than one name on a card?
I don't know what that means.
I think if the insurance company is showing up a few different ways on the card itself is maybe what I'm...
I've never seen that, so I'm not clear what that means. To the best of our ability, we need to list individual policies. So, I mean, if someone has two different types of coverage, like sometimes what happens is they'll get a major medical plan and they're like, especially working for the state, I know this is true for us, our vision coverage is covered under a separate vision carrier. And so they might list their major medical under MODA, and they might list their vision under VSP, and they might list their dental under something else. So there could be 3 policies for someone who's fully covered. So we want each one listed separately and individually by name, if that's what you're asking.
And then maybe we can also follow up offline with some examples to educate ourselves and to get better answers for you, Christy.
That's a good suggestion. If you're seeing something and you don't know as a community partner and you don't know how to handle it in terms of reporting it in the one system, please do send it to us so that we are aware of how this presents out there in the real world. As a side note here, and to give Jessica time to think and sort through these questions, the last question that just popped up is, will we need to be associated on a case in order to report TPL? And we will get to that in just a moment, so hang tight on that one.
Yes, some of you are asking excellent questions that we're about to answer, and I'm excited about that part of it. So maybe I will continue to look through this while you go ahead, Deanna, and I'm so sorry, y'all. There's just a lot of really good engagement.
Thank you. Okay. Okay, so our next guidance here is that we have this link called reporttpl.org. That is a vanity URL. It goes to a state website that allows you to report somebody's other medical coverage. We used to advise people to report there all the time. We are not advising that right now. Having duplicate records creates duplicate work for our workers. So our updated guidance is only use reporttpl.org if you're unable to report in one for some reason. Maybe one is down, maybe it's a paper application that you're using today for whatever reason. We hope that's not too common. You can use reporttpl.org to report that third-party liability if the TPL doesn't show in MMIS within 30 days. So if it's not showing and you need to push it through, that is a way to alert the agency. And then we'll talk in a minute about what to do if that 30-day timeline is too long because you have more urgency than that. But if you don't have urgency, that is a way to do it and not have to worry about being on the phone or anything like that. You can also report it there if the client is incorrectly enrolled in a CCO. For example, they actually do have other coverage. They are mistakenly enrolled in a CCO, and that cues you in to the fact that we don't know about that other coverage. You can report it through reporttpl.org. And then, let's see. So reporttpl.org is where you can report that other TPL, but it also has a secondary function. You can also type that policy into reporttpl.org, and that is your way to apply for what's called HIP. That's Health Insurance Premium Payment Program. And we could do a whole webinar on the HIP program. So we're not going to do that today. We're not going to do a deep dive on the HIP program, but I do want to make sure people know it is part of this puzzle. And here's how it works. If somebody has other major medical coverage, for example, through an employer, and it costs them $100 a month, they can, once that insurance is active, they can request OHP to pay for that other major medical coverage, and OHP goes through an equation to see if it financially makes sense to just pay the premium and the other costs on that other coverage and have it be primary. Now, it will always be the primary coverage if there's other coverage, but sometimes OHP will pay for it. And if you want OHP to consider that, then you would also go to reporttpl.org to ask us to pay for that other coverage and to see if that will be approved. In fact, I'm going to take us on a little tour of ohp.org. Oh, where'd it go? Sorry, guys. Here we go. This is reporttpl.org. Oh, actually, I apologize. Reporttpl.org takes you to the health insurance group, where you can report private health insurance. So you would click on this Submit Now. There's also frequently asked questions. There's a lot of resources here. But you would click Submit Now, and you will get to a list of documents that you will need that will be helpful. Insurance cards, digital copy of last 2 pay stubs, if you're applying for that premium reimbursement program, that HIP program, and some other documents. You will enter. I'm not going to go through this, but it will ask for contact information. It will ask for the insurance company name and the policy number and the address and all of that. So instead of typing this in, I just wanted to let you know that this is what the website looks like. and this is also where you apply for health insurance premium payment. Okay, and now we're going to go back to our slideshow. Are there any questions about what I've covered so far before I move on?
I'd like to just add, if I could, this is Christy Taylor. It's important that to call out again that HIP is only available for employer-sponsored policies, not privately purchased policies. And what happens is they would send us a copy in the process. If they request HIP through reporttpl.org, the HIP program folks will reach out to them and confirm how much they have removed from their paycheck for the premium cost. And as Deanna described, they will do an evaluation of cost effectiveness to see if they qualify for payments. And if so, they will set them up to just be mailed a monthly check that will reimburse them for their premium amount as a separate check. And that's just kind of overall how that works. But it's only for people who have already been enrolled in their policies, not for those who have policies available and have not yet signed up.
Thank you. That's a really important clarification. All right. Here's a question that somebody asked. What if you know that somebody has other medical coverage, but you're not the community partner on record? What that might mean is that you're a provider and they're coming to you because you're a provider and you see that they have other major medical coverage, but you don't see it listed in MMIS. Or there's a change to that major medical. It is showing in MMIS, but they don't have it anymore. But you're just a provider, you're not their community partner. That may be a scenario. If that's the case, providers can report changes, report either TPL or changes to TPL at that web form, reporttpl.org. If there's a provider who's not a community partner, they can still do that. That is available to providers. I'm going to pause there and see if Jessica has anything else to add to that piece before we talk about other CPs who are not associated.
Yeah, I think, well, this is in alignment with what you're probably about to say, but if you are a community partner who also has, you wear a provider hat, you have other job duties where you would be doing this outside of being a community partner, then you do not need a consent form because you're working within your rights as a Medicaid provider. However, if you are being a community partner, if that's the hat you're wearing, then I think the rule that Deanna is probably about to reiterate, and I'm jumping the gun here, is that the consent form really is that central piece of having permission to do things for your client. So if you're wearing your CP hat, anytime you collect any personal information, have a consent form. Whether or not you send it to us, you should always have it on file. But there are definitely times where providers can use it. They do not need to get a consent form if they're acting as a provider. And I know that sounds tricky, so let me know if I have made it more or less clear.
Thank you, Jessica. That's perfect. So for those of you who may be newer, you might be a community partner. Somebody comes to you and says, maybe you're at a clinic and the clinic is relying on you as the community partner arm of that clinic to help somebody report changes to their TPL. But you're not associated with them. Somebody else helped them apply, and maybe they want to stay associated to that other community partner, right? They don't want you to take over that association and get connected to them in the applicant portal. That's okay. You can just have them fill out that consent form so you have permission to help them. You can collect their other medical coverage information, and you can report that at reporttpl.org for them. Just keep that consent form on file. Like Jessica said, I'm sorry I'm repeating it, but you don't need to send it to us and change their association or who's connected to them. You're now protected because you collected the consent form and you can help them report that coverage or that change in coverage. We did not get to that part of the form, but at Report TPL, there is a question about safety concerns or barriers to accessing that TPL. Because we have a provision that says if you have other medical coverage, that other medical coverage will be primary and OHP will only pay as the secondary payer. However, If there are safety concerns associated with accessing that coverage or other barriers, such as that other coverage only covers providers that are too far away from your home, then we can consider OHP as primary. So if there is a question for that, at reporttpl.org. All right, any questions before we move on how to escalate urgent cases? I'm hearing some silence, so I'll move on. To acknowledge that sometimes waiting for our state processes to get to a piece of information and enter it and have it show in the system is not the timeline that your client needs to address their urgent medical needs. So if there are urgent access to care needs, there is a way to expedite reporting of or changing of this other major medical coverage. Now, a little note here, billing issues are generally not considered urgent. The urgent process is really about clients getting the care they need to address their medical problems. It's not about providers getting paid. So please note that. And with that, there is the health insurance group that we went to their webpage a moment ago. And there are 2 ways to contact them if there are urgent access to care needs regarding the reporting of or the changing of other major or other medical coverage. So you can contact the health insurance group either with a phone number or through their email. And their email is tpr.referrals with our new ending, odhsoha.oregon.gov. Now TPR is correct. It is not a typo. It is not TPL. It is tpr.referrals. So just calling that out, that it is correct because it sometimes gets questioned. And when you call them, you'll need to provide the recipient ID, other coverage ID, as well as the OHP ID, their first and last name and date of birth, last 4 of the social, if they have one, and the TPL carrier, policy, and group ID, as well as when that coverage started and closed. So that's a lot of information that you'll need. Be sure to have it before you contact the health insurance group, so that can be a complete request. All right, now I will pause to see what questions we can answer.
I do want to say that we had someone call out that when you email the TPL team, they are amazing. So it's always good to hear when things are working well. Yeah, so excellent. And then I guess I just want to say this, and I'm not sure we have an answer, but someone says, I've been told that ER behavioral health doesn't count as an urgent time. Is that true? And that might be something we want to get some clarity on with maybe some case specifics.
We are in discussions right now about the urgent criteria for expediting TPL. So that would be great to get specific scenarios to feed into our discussion to make sure that we're including those when we discuss those criteria. You can email either myself, Jessica, or I can put in my email into the questions box. Actually, Jessica, if you can put both of our emails, that would be great. You can also contact our general community partner team, which is community.outreach@odhsoha.oregon.gov. In fact, there is the email address. So that is the end of our content right now. And I want to be sure that we are answering anybody's questions with acknowledgement that navigating TPL is challenging right now. And there may be a lot of cases that don't fit exactly into this guidance. You should reach out to your ROC with those. Those will inform our process as we move forward, trying to improve the TPL reporting system. I think a lot of these questions have been answered via the chat box and replied to all, so you can all see the answer.
I was trying to decide about which ones we want to say out loud now that we are at the end. And maybe, oh goodness, I want to thank you all for the really great questions and engagement. The fact that it has made our job harder is a great sign. There's a lot of great stuff.
I do, while Jessica's trying to scan through those and figure out which ones to perhaps read out loud and address out loud with our extra few minutes here, I would like to address a distinction and make a distinction between somebody having CCO coverage in a different area. So let's say somebody is, they were in Klamath Falls, they had Cascade Health Alliance, and now they've moved to Central Oregon, which is a Pacific Source area. And they come to Central Oregon and they are having a hard time getting into a doctor because they have Cascade Health Alliance, and doctors here in Bend and Redmond and Madras don't contract with Cascade Health Alliance. So they're now in a different CCO area. That is different than having other major medical coverage. But to address the question that came in about that, the home CCO is responsible for that client's care regardless of where they are. So if they're traveling and they need urgent care, that should be covered by their home CCO, or if they're temporarily away from home, they need to call their home CCO to coordinate their care outside of their normal service area. And that is different than having private or employer-sponsored coverage and navigating that. But I think it's really, it shows up a lot and it's another challenge. So I did want to call that out and address it.
Thank you, Deanna. And maybe I'm gonna start reading some of these, and Christy, feel free to interrupt me at any point in time or to help me clarify if I'm not being clear. But I did want to sort of start from some of the early questions. There are a couple that are around, what if people have access to TPL or their family has access to TPL? And I want to clarify that the pieces we're talking about today are only about things that are active, things that, either TPL is active or was and needs to be turned off. So this is separate from questions about what other types of coverage does someone have access to. What we're interested in today is who on a case has other coverage that they are actively receiving, including access to coverage that they don't actually have meaningful access to. So Deanna talked a little bit about having a good cause reason for not being able to access coverage. Like, those details are very important. And it is not required that someone who has coverage cover everyone else in their family. And so there are going to be situations where it will only be one person on a case who has that TPL and other people do not. And it also may be the case, and I'm trying to get a bunch of questions in one, which is why I'm rambling a bit, where the policy holder, the person who actively is in charge of that coverage, is not in the household. And so those are all pieces that Deanna showed ways in which our system is getting smarter every day about how to handle those, but we do need those details. So that was one thing I wanted to tackle, and I think that was 3 or 4 questions all in one. Did I make sense? And or did that bring up new questions for folks? Let me double check. Okay, because I do think those are important details that are worth reiterating. And then I do also just want to say in general, if there are things that are specific to, and I'm reiterating myself again, to how MMIS is or isn't showing things, let's follow up offline. Feel free to reach out to me via email, because we are here, we mostly know about what happens in one, and we know that it has implications for MMIS, but I don't think anyone who is here today presenting has really in-depth information about what those MMIS screens look like on the other end and how to best navigate those. So happy to do that elsewhere, but I don't think today is a place we can tackle that.
I see a question that maybe Christy can answer, or maybe not, but I'm going to summarize it. Really, it's a question about when somebody reports third-party liability or other coverage through the reporttpl.org because they couldn't report that initial coverage or the change in the one system for some reason. What then is the process? And when is it expected to show up in MMIS? What would be that expected timeline?
If coverage is entered in one.
No, when somebody reports at reporttpl.org, because they couldn't put it into one.
Yeah. So our HIG team, Health Insurance Group, that processes these, they process referrals that come through Report TPL, and they process the referrals that come through one. And so they basically have two different work queues depending on how the information is reported. And they prioritize, I mean, they have to juggle both in their daily work priorities and which one's backlogged and which one's taking longer. So there can be a difference, FYI, between the timeliness of something reported in one versus through the web page. And it can vary, but they're trying to keep them more equal now. It totally depends on HIG's backlog of work and how far out they are in processing, and that varies. That has varied throughout the past year, especially. I think if HIG is processing within a couple weeks of getting the referral, and they're able to quickly contact the carrier and verify all of the policy information is correct, they can build the MMIS record in about that amount of time. If the record isn't complete, or for whatever reason, like they aren't able to verify the policy, then it can take a lot longer or never show up. That's why. So a lot of time, I do want to take a minute to say this. A lot of times people will enter a TPL record because they know that there is TPL, but they don't know the policy number. So they put 99999 and they use some default fake policy number. HIG will not be able to verify that policy or add it to MMIS if they cannot contact the carrier and confirm the information. And without even a policy number, it's unlikely that they're going to be able to verify that person's coverage at all. We really need to encourage everyone, please don't use default data. If you need to get correct data and build the record correctly, or it can greatly significantly impact HIG's ability to verify the record, like ever. Sometimes many are sitting there forever because they're entered incorrectly and HIG simply can't verify them. They don't have enough information to identify. So right now, I think it's taking 2 or 3 weeks in general to answer your question for them to show up. But we want to give them some variance, and that's why we said if it doesn't show up within at least 30 days, that's when you need to sort of reach out again just to make sure that it didn't error out, and we made sure to get the information.
Thank you, Christy. Here's a clarification that somebody's looking for. If a person has TPL, it shouldn't be removed, right, if it's showing. So that's correct. But if they're not covered by the TPL, if they have TPL, it means they're covered by TPL, but there may be an access to care issue or sorry, how did Jessica put it? Barriers to using that coverage. It may be distance, it may be safety concerns. In that case, the TPL shouldn't be removed, but we need to know that there is good cause for not requiring that TPL to be primary. And you can do that through the HIG group and through that reporttpl.org, right? Is that the best way to do it, Chrissy?
Absolutely. Yes, that's all correct. I'm also reading the question, and I do want to just also say, if this is what you're asking, if they're not covered by the TPL, then it should be removed. It should only be coded on their record if they are covered by it.
Right, if they're covered by it, but not if they simply can't use it for some reason.
Yes, correct.
Okay, great. And can we speak to if there is a role at all for client services unit in all of this?
Yeah, I was thinking about that. I think a lot of these questions really live at the intersection between the TPL work and client services work. So I think the answer is absolutely yes, because client services are the folks who can then help you work through and help members work through their CCO enrollment and disenrollment options once the TPL has been correctly added, removed, resolved. I think it really does hit on two different teams, and that's part of why we're having these complicated conversations, because they also might have different definitions of what counts as urgent and how they deal with those things too.
Yep. And I think that we are still, right now, what I don't hear is I don't hear us having guidance about when to contact HIG through the phone number or the email, or to contact CSU. Although I will say that if you have changes to other medical coverage, those changes should go through HIG, that reporttpl.org. If you either report them through one, if you can't report them through one, report them at reporttpl.org. And if you need to expedite that for access to care issues or medical urgency, then that's when you contact HIG directly with the phone number or the email. So I'm going to go back to that hierarchy email, or the hierarchy slide, which I kind of grayed out one of them. Where is it? Here we go. Always report through one if possible. Use reporttpl.org. If you can't use it in one, if you can't do it in one, or if it's not showing, and you have some timeline leeway, or if you have urgent access to care needs, you can contact HIG directly. I think the clarifier that I'd like to say here is you shouldn't report on the web form at reporttpl and call or use the email. Those are redundant, so do one or the other. Is that right, Christy?
Yes, please.
Yep. So we're trying to avoid double reporting here because it presents challenges on the processing side. And I also want to acknowledge that this remains a little bit murky and what's the word? It's not really clear because we have some challenges with our processing side with the system. So we are still working on how to clean all of that up, make it a better system. And for right now, this webinar was an opportunity to provide you with the current guidance, but also hear what you're experiencing, which will inform our continued discussions. So with that,
I do want to say when it comes to the TPL, sorry, our acronyms, and CSU distinction, let me know if I have this right. My understanding is it's a lot like when we have to update someone's address and change a CCO, which is the address part has to live at the processing center. But once the case has been updated, then it's client services who can walk through any of the opportunities for expediting CCOs, moving people to open card, things like that. So I think of the TPL as being very similar. There's a specialized group of folks and specialized tools for TPL. And then once that is in order, that's when CSU can take additional action if people have urgent needs beyond the ending of the TPL or the starting of the TPL. Does that sound right? So like it's one of those things where the distinction to me is once the TPL is accurately in our system, that's when we might want to tap additional resources outside of HIG.
thank you. That's helpful. I'd also like to address one more question that's in here, which is really about this hierarchy. Somebody's saying, is it preferable to report initial coverage or changes through the one system only and not the TPL site? Yes, that is ideal. The ideal situation is you report through the one applicant portal whenever possible, and you put in as complete a record as possible. The reason for that is one determines eligibility and pushes enrollment preferences. One needs the TPL information to make an accurate eligibility determination. So for example, a kid who is with that higher income with the CHIP level funding for their Medicaid can't have TPL and OHP at the same time, right? So if that child has TPL, it will impact their eligibility if they're in those higher income ranges. So we need that TPL information for accurate eligibility determinations, and that lives in one. So yes, report in one if at all possible. One will also then, push a CCO enrollment request. So we need to know about that TPL so the CCO either enrollment or no CCO enrollment happens correctly. So always start with one if at all possible. And then we have other options for you when that is not possible or when the timeline of reporting in one doesn't work. So I hope that is helpful. And again, we know that one doesn't always capture it. And so that's why if after 30 days you don't see it in MMIS, that's when you could then do that secondary reporting at reporttpl.org. And I don't love this guidance. I don't think any of us love this guidance, but it's what we have right now. So we wanted to share it with you to help you navigate getting your clients and your members properly situated with their other coverage. Right, Jessica,
I do want to say, I'm not sure if people are asking it here, but I have sort of heard elsewhere, there are limitations we have around, sometimes people have TPL that they don't have direct control of and they don't want to have it. And we have to work with what is, not what people want their situation to be. And sometimes I've seen some pretty tough situations with TPL on that front, especially in the case of, for instance, a minor who it's a parent who has that coverage. So I just want to be clear that there are some times where people want to remove TPL so that they can have a CCO, but they do truly have that other coverage. So we have to work within that framework. And so there are some times where we do have to have those tough discussions. So I'm sort of seeing hints of that in some of these questions. And I just wanted to directly respond to that. But if they have a good cause reason they can't access it, that's also an important detail.
Excellent, thank you. Well, we definitely have some things to follow up on. I know that we have responded to some of your questions privately to say, let's look at this case offline, and you can send those cases to both Jessica and myself. Please send them securely. And with that, I want to thank everybody for being here today. Thank you for your excellent questions. We'll continue to work with you and together figure out what this looks like going forward. But always reach out if you need anything, and have a terrific Wednesday.
Thanks, everyone, and thanks, Dean.